I'm going to invite Dr. Mohit Dogra. He will talk about indirect ophthalmoscopy, retinal drawing, and fundus photography.
Thank you, sir. And Dr. Majumdar is always a tough act to follow, but I'll try and do whatever I can say. And I think it was just a perfect kind of prelude into my talk when he finished with the retinal diagram of how to represent intraocular infections. Part of that will be covered in what I will show. I'm not going to be speaking on indirect ophthalmoscopy or fundus photography. It's just going to majorly be on retinal drawing and how to correctly kind of demarcate and show and actually highlight different things. That's the Amsler-Dubois cartogram. Anybody wants to quickly show those three concentric rings, what they stand for? The innermost ring is for anybody, just is the innermost ring the aura? The equator. The middle ring would be the aura, and what about the third ring then? Pars. It has to be a junction, right? Aura is a line, equator is a line, pars plana is a structure. So it can't be demarcated by a line. It has to be a junction of two things, right? So it's a junction of the pars plana and the pars plicata. So it has to be a line, right? And why would you want to show that? I mean, most of your retinal drawing should finish at the aura. What's there to see, or why should we be interested anterior to the aura? Anybody? Vitreous base, you've heard of the vitreous base. It'll straddle the aura. It has connections anteriorly. You have certain, uveal issues, uveal pathologies that might arise from that area. You could get ciliocoroidal detachments secondary to certain retinal pathologies. So all of those will be seen there. You could have microcystoid degenerations and other things, and you might want to show them there. So hence these three, just the basis: the innermost circle, the middle circle, and the outermost circle, right? And the bang center is not the center of the universe, so it's not the center of the optic disc. The optic disc is to one side, and typically it will be to one side, which will correlate with the clock hour, which is 11 up top and 7 at the bottom. The center will be the fovea, hence you will have asymmetric distances. So from the disc all the way up to the periphery, about 23, 24 millimeters, and from the disc all the way to the aura nasally would be about 18, 18.5. So the center is not the optic disc, the center is the fovea. And depending on whether you are representing the right or the left eye, the disc will be on either this or the other side of it. This is just indirect ophthalmoscopy, and as I said, I'm going to skip that. I'm just going to look at, how to represent once you've, seen what you saw, how do you adequately and accurately represent it so that even if there is someone who did not see the patient, if they were just to go through the chart, or if you were to try and explain to them, they would have the same picture as to what you saw. So retinal detachment, we're going to just start off from there and look at different things because it's going to cover different aspects of the retinal drawing. So you want to look at the optic disc, the fovea, the retinal vessels. You want to look at the extent of the retinal detachment, identify the breaks, the clock hours, the position, PVR changes if they are there, and represent them adequately, choroidal detachment if there is there or not. So that's actually showing fairly well. That's a pseudo-color ultra-wide field optos photo. You can see a fovea involving inferior retinal detachment. And that is the same patient, just a more decentered photo, and I think you can see the break right there. And that is a representation, your Amsler-Dubois cartogram, just to show that white thing is just to de-identify the patient. And the idea is that anytime you want to try and reproduce something at any forum, please try and de-identify the patient and not have patient names, age, sex, and other demographic details. So, I think all of you know detached retina is blue, light blue. The outline of the retinal break is a darker shade. The retinal break per se is red, and then that will actually tell you what is going on and what is not. So no PVR apparent, no PVR shown, no choroidal detachment, and single break. So this is one of the most simpler, straightforward representations. But you actually have to see as to where the extent is, where the break is. You can't make that break, inside the first line, because you can see on the centered ultra wide field image and the inferiorly decentered image that break is just outside of what you would say is the equator. So it has to be adequately represented, because the management then, of course, depends on that, whether you want to buckle this or not. Another photo, and if you can see right there, there is a horseshoe tear, if it's actually visible, and that is actually shown as so. Simple, no retinal detachment, the entire retina is in a light shade of red, and you can see that the outline of the horseshoe tear, along with the localization and where it exactly is actually shown there. This is actually pretty anterior, almost, I'd say, if you were to look at the equator and the aura, this is actually more towards the aura, hence has been shown there. And these are simpler things to kind of show. This is, this now has a bit more of a retinal findings to it. So retinal detachment, you can see that big break inferiorly. You can also see a lattice, so you can see all of those things. So a total retinal detachment, albeit shallow. You can see a lattice, which is that thatched thing, which is upper temporal there, and you can see the location. It is between the equator and the aura, and there's this large break, which is again shaped as so. So no PVR changes that you could see, so none have been shown per se. This patient now has a choroidal detachment. You can see that there is, a scleral buckle is in place, a rather high posterior buckle, and you can see that there is a choroidal detachment nasally. So you have to show the presence of a buckle in the diagram. You have to show the presence of choroidal detachment in the diagram, and so that's what you have. You have that brown big thing, which is nasally, which is the choroidal detachment. You have the buckle, which is that shaded, almost like a spoke wheel pattern going all across, which is the area where the tire is, and that's actually seen there. And the band is that narrower thatched thing that you can see, which is actually right there. And these are certain other things that you might want to show, but we're basically going to come to this. So you have 5 or 6 different colors. If you have a blue solid color, which is I think the most commonly used, it's typically used to signify detached retina, retinal veins, outside of outlines of retinal breaks, outlines of the ora serrata, meridional, radial, or fixed retinal folds, outline of flat neovascularization, very seldom used, but that is what it typically should be used for. Outlines of retinal of lattice degeneration with that thatched X kind of appearance, outlines of thin areas of the retina, and intraretinal cysts, as has been shown in the image right next door. This is also, as you can see there, so the breaks, the outlines have to be blue, the center of the break has to be red. You can see retinoschisis. I was asked by someone, so right there is how you would want to show retinoschisis. It's almost like lattice, except you don't make thatches, you just make arrows pointing one side, and if you have 2 layers of your retinoschisis, then the inner layer is angled one side and the outer layer is angled the other side. Now, how you see both on top of each other beats me, but that's what's written, because once you make in a diagram, one layer that way and the other layer that way, it almost looks like a lattice, but that's what it said, right? And then you come down to red, which I think is, along with blue, the most commonly used color. Retinal arterioles, neovascularization, vascular anomalies, vortex vein, attached retina, hemorrhages, pre-retinal and intraretinal. Interior of retinal breaks, which we have seen, interior of outer or inner layer holes in retinoschisis, and you can see a representation of all of those things, in that corresponding diagram. Then you come down to green, which is also fairly commonly used. This could be solid, or this could be stippled or dotted with kind of a broken appearance. So one quick thumb rule is that anything in the vitreous which is not meant to be there, which is either degenerative or secondary to pathology, is green. So your vitreous haze, your vitreous hemorrhage, your posterior vitreous detachment, your snowballs, your snow banking, anything in the vitreous is green. So when in doubt, if it's in the vitreous, please make it green. Anything within the retina, or pertaining to the retina, for the most part is blue. Anything in the subretinal space, not on the choroid, is yellow, and anything in the choroid is brown. So if you know this, I think for the most part you have 80–85% of your things as far as the retinal diagram is concerned, that's actually sorted. And then you come down to a black solid, which is again not that commonly used. So typically used to signify pigmented, kind of things that you see in the fundus. Could be old cryo marks or old laser marks. Could just be demarcation lines that you see in chronic retinal detachments or other hyperpigmented areas or lesions that you might see, your congenital hypertrophy of the retinal pigment epithelium, Grupcher, P, or solitary, or whatever. Generally not commonly used, but anything which is pigmented will be shown, will actually be shown by black. One of the lesser commonly used colors to signify structures in retinal diagrams. Yellow solid is important if you want to do, I think is used a lot more commonly and a lot more frequently when you want to try and signify posterior uveitis, because active retinitis is yellow, active choroiditis is yellow. It depends on the differentiating thing is that because the choroid has a lobular anatomy, you try and draw the active choroiditis in more of a amoeboid yellow pattern and not disjointed. Of course, you can have multiple ones, but each of them will be amoeboid because of the lobular architecture of the choroid. The retinitis will be either one continuum or will have different areas like that, like stripes. So yellow, the color is the same. The depiction of retinitis choroiditis is actually different. And there was a brown there. I think we actually glossed over brown, which is the second last slide, actually. So anything in the uvea. So typically, your three most common things that you would highlight or show in brown are your choroidal masses, melanomas, metastases, or any other masses. Your healed choroiditis, so active choroiditis is yellow, the healed choroiditis will be brown, and it will also show your tires and buckles if they are in place, if you're speaking particularly for post-operative eyes of retinal detachment. And for all of this and more, I think this, there's a pretty good article, a review article by, in the IJO, I think late 2022. It gives great pictorial representation of both anterior segment and posterior segment color coding. I think if you go through that, just look at the photos that the author has shown. They are self-explanatory. They tend to cover most things. And with that, I'm happy to take any questions if there are any. Thank you.
Nice presentation, Dr. Dogra. I want to ask you one thing, very simple thing. For the young ophthalmologist, what is your suggestion? Like in the era of wide field photography and ultra wide field fundus photography, what is if the young ophthalmologists are whether they will lose the interest in doing indirect ophthalmoscopy and just to get rid of their back pain or not?
So I think it's a two-part answer, sir. Whether they lose interest, I think yes. Whether they should lose interest, I'd say no.
People will be a little bit reluctant to do the indirect ophthalmoscopy because
absolutely.
Everything is visible in optos.
Absolutely. So we see it. We've been seeing it, as you've rightly said. Ever since we got the ultra-wide field optos, that most of the times any posterior segment pathology, the case which is being shown to the consultant will already have a photo. And based on that, it'll be said कि इसमें break नहीं पता चल रही है, because the break might not be visible on the photo no matter how wide field it is. But depressed exam, it is so a photo is not a substitute for a depressed exam.
Yes.
A photo is great. A photo might supersede a depressed exam in certain circumstances.
Right.
But both of them are mutually separate of each other. Are I'd say in fact complementary. And if anybody wants to do retina practice of any seriousness, I think indirect, skill is a must. I would also say, and this might be controversial to many, that a lot of postgraduates now, would not want to do indirect. And I don't think it is mandatory for them to know indirect. They should try it. They should know it. But if you don't know, it's not the end of the world. But if you want to do retina and you do not know, you either cannot or you do not do indirect, then please change I would humbly say, please change your decision and do something else.
Basically, they should know what are the drawbacks of doing the wide field photography. Basically, the inferior part of the fundus is not readily visible. You cannot detect a flat HST. Number 3, you cannot detect sometimes dialysis can be missed because anti-retinal is doing the indentation ophthalmoscopy. You cannot get the dialysis.
Also with eyelashes, sir. And
eyelashes.
And people with deep set eyes.
Yes.
And it's very, very, you might be seeing a lot of things otherwise, but the image might not come as great because you can have a nose artifact.
Yes.
You can have lots of eyelashes which will actually impede a lot of the view.
Even within a CRA patch, a retinal atrophic hole is there or not, whether should we do laser or not, that is also important.
Absolutely.
And also the 3D structure of the image, 3D perception of the whole system of the fundus, whether any traction is visible or not, that is in a 2D picture of Optos is not visible.
Yeah, for vitreous, absolutely. So for the vitreoretinal interface or for vitreous visualization, ultra wide field, I think the resolution is exquisitely poor for us to comment on that.
Right.
Yeah, I think you have just answered most of the things. I still would like to throw a one controversial thing to you.
Sir.
Is it really very useful to have the retinal drawings when you have a good photograph with the Optos?
I'd say, sir,
Because
yeah.
you are completely visualizing everything with the colors and everything on. Of course, there is a artificial colors are there.
Absolutely. So,
But when it is not so, like you take it as Optos, of course, gives a lot of artificial colors.
sir.
The add-on probably is a little better than in that.
So-
So in that case, do you really feel that the fundus drawings are going to be still critical?
Yeah, so 3-4 things, sir. I think that's a great question and multifaceted, but if I were to answer that quickly, the technology is not that widespread. I think there are a lot more people doing retina and ophthalmology than there are these fundus cameras out there. I think they're expensive, they're not easy to come by, not everybody has access to them, that is one. I think documentation is the need of the hour, not just for yourself, for research, but also for medical legal purposes. You fix a retina and you did not have, and for most parts, for the most part, most people do not do a pre-operative retinal detachment imaging. Yes, the patient had no vision, but that's subjective. Yes, the patient gained some vision, that is also subjective, and the patient has an attached retina later on. If there's a medical legal case, you can always take a photo then. But if you do not have documentation prior to that, you could be dragged into court. You could have other things going on. Was surgery necessary? Was there a break? Was there just hemorrhage that cleared? So documentation from that viewpoint. Then also for teaching, I think it's very, very important if you have fellows, if you have people you want to teach when to do a buckle, when not to do a buckle, what is a buckleable kind of a break, what is a posterior break, do you still want to try and use sponges? I think the ultra wide field imaging kind of falls short at this point in time. I think a fundus diagram with all of those 12 clock hours, those 3 circles is a lot better because it will give you more information, also help in a teaching scenario.
Wonderful, because why I am just asked this question is because we should not take things as little lighter and then start stopping doing the indirect ophthalmoscopy or the drawings. As of today, we still need to have the documentation done properly, and I think you have very well clearly said all the points why we should be doing both. Thank you so much.
Thank you, sir.
Oh, sorry.
Yeah, I think no.
I couldn't see you.
Just a response to the last question where he's answered it properly. But the point regarding the learning the indirect and there's a subtle point over there that all the imaging modalities have, not all of them are true color. Some of them have false color. You may not on these imaging modalities be able to distinguish a hemorrhage from a pigment or an atrophic area from fluid. So when, like Mohit has mentioned, it is the drawing with color is mandatory to organize the diagnosis in your mind.
Yeah.
So when you know on a picture where to draw green, blue, yellow, brown, and black, then automatically you get to know activity, inactivity, recurrence, hemorrhage, source of hemorrhage, all those things, the picture comes into your mind and you make a proper diagnosis. So I would say as a postgraduate young ophthalmologist, even as a retina specialist, drawing is mandatory, imaging is confirmatory. That's the best we can say it is.
Thanks, Dr. Unni. And as a glaucoma people, we are very happy with our fundus photographs than what our drawings are.
Also, if someone's a great artist, sir, if they can make an excellent diagram, they can submit it to the AIOS as a video, as a picture, as art, and get an award out of it.
Thank you.
Thank you, Dr.